Hi, my name is Tim Musock. I'm with Bradford Barthel. I'm in our Sacramento office, and I do AMA analysis and ratings. I'm not an attorney. I do ratings. I've been doing ratings since a long time, since probably 1989. I've been an instructor with the Insurance Education Association since 1991. So I've taught 4 different permanent disability rating courses through the Insurance Education Association, as well as other courses for them. My co-worker in the rating unit is Marlene Phillips. She's in the Ontario office. There's our contact information. I'm in the Sacramento office. Marlene is in the Ontario office. Ratings at bradfordbarthel.com reaches both of us, and you can get information about referrals, rating referrals on our website. We've included the link there. Today we're going to talk about some rating issues. As Tammy said, those are the rating issues that we're going to cover. Over the next few months, we'll be covering some other permanent disability rating webinars. Last month, Marlene did the rating schedule, the 2005 permanent disability rating schedule. This month, we're doing rating issues. These are some issues that different people have asked about and requested training, so we've incorporated it into this 1-hour session. Coming up over the next months, we're going to do the AMA guides. We're going to review Chapter 15, the spine, Chapter 16, the upper extremities, and Chapter 17, the lower extremities. So with that, here we go. We're going to start talking about Labor Code Section 4660.1. And Labor Code Section 4660.1 is effective for dates of injury on or after January 1st, 2013. So we're 3 years into it, but I just want to make sure that we all understand what this includes. A couple of important elements in terms of disability rating. Number one, the adjustment factor of 1.4 for injuries prior to 1/1/2013. We use the FECs 1 through 8 from the Permanent Disability Rating Schedule. For any injury on or after 1/1/2013, we use an adjustment factor of 1.4. I'll talk a little bit more about that in a little bit. The second important element in terms of changes with respect to Labor Code Section 4660.1 is right there on your screen. There shall be no increases in impairment ratings for sleep dysfunction, sexual dysfunction, or psychiatric disorder, or any combination thereof arising out of a compensable physical injury. You can still have an injury that requires treatment, an entitlement to treatment, but not additional impairment. It seems as though not all doctors are aware of this, so occasionally we still get reports from QMEs, PTPs, that want to include sleep dysfunction or sexual dysfunction along with that. So I want to keep that in mind. Not all doctors are aware of that, so we need to be. This next slide is taken from the 2005 Permanent Disability Rating Schedule from Section 2, and it's the FEC Adjustment Table. Just wanted to show you what that is, and that's discussed on pages 1-5 through 1-7 of the rating schedule. And what the FECs were ratios of average standard ratings to proportional wage loss with data that was compiled with respect to claims up until the 2005 PDRS was being put together. So the higher ratio of ratings to proportional wage loss resulted in a lower FEC, and we have FECs of 1 through 8 as shown there on page 2-6. In FEC, there's a second page to that, just showing one page. The FEC of 1 correlates to a 1.1 adjustment factor. The FEC of 8 correlates to a 1.4 adjustment factor. And that's what we're using now for dates of injury 1/1/2013 and thereafter. So you can either do the math, multiply the WPI by 1.4, or you can look in your schedule and use that 8 FEC rank. They come up to the same adjustment. Next section we're going to talk about is pain and how to rate pain. Pain is discussed in the AMA guides in Chapter 18, and there's some instructions about how to do it. There's some caveats within Chapter 18 about how subjective pain is, and it's different for different people. But ultimately, they conclude that you can make a discretionary quantitative pain-related impairment of 1, 2, or 3%. The DEU long ago adopted the position that there must be an underlying impairment in order to add pain. That also was affirmed in the Blackledge and Bank decision in 2010. And what those say is that you can't add pain to a 0 WPI. So there must be an underlying impairment in order to add pain. However, there may be exceptions. In 2013, the Third Appellate District Court ruled in the City of Sacramento versus WCAB and Arthur Cannon that said that in that particular case, the doctor's rating by analogy was appropriate. And in that case, the doctor, who was an AME, said there were no objective abnormalities were identifiable, but he continued to experience pain in his left heel that affected weight-bearing activities, and it was determined that that pain-related impairment without an underlying impairment was accepted in that particular case. And what I just want to point out is that no two cases are the same. This was an unpublished, non-binding decision, but one of the things to remember is that this was an AME that did it. The AME provided reasoning and explanation as to why that would be appropriate, and it was accepted that way. Pain. The 2005 Permanent Disability Rating Schedule talks about pain and how we should use it. On page 1-12, says it's to be made at the whole person level. So if up to 3% for pain can be added for any single injury, and it's added at the whole person level. So for example, if an elbow were to be increased by 3% for pain, the rating for the elbow would first be converted to the whole person scale and then increased. The resultant rating would then be adjusted for diminished future earning capacity, occupation, and age. This is directly from the rating schedule, and so it tells us how to do pain-related add-ons. It also says, that next paragraph, that if it's appropriate and a doctor is applying more than 1% pain, or any level of pain, needs to indicate how that's to be distributed. If there's 3 different body parts and the doctor just gives us 3% for pain, that's really not enough. We need the doctor to tell us where that 3% goes. Does it go to one of the body parts? Does it go 2% to one body part, 1% to another? Or is it distributed evenly, 1% each? So the doctor should be giving us that assessment when they do their WPI assessments. One of the things that we know is that many doctors really aren't all that familiar with the rating schedule. They know the AMA guides very well, they know medicine very well, but the rating schedule they're not necessarily well versed on. So this is another error that the doctors sometimes do. They don't necessarily always understand that they need to distribute that 3% for pain or 2% or whatever they're adding. They've got to indicate where that's going. So an example of how the pain is included in an impairment rating, if we have for instance, a 41-year-old truck driver with loss of elbow range of motion. Elbow range of motion gets calculated at 10% upper extremity, for example, and the doctor also offers 2% WPI for pain, we need to add that pain to the whole person, to the WPI. So the 10% upper extremity for loss of motion is converted to 6% WPI, and the 2% WPI for pain is added. So 8% WPI becomes the standard WPI for rating. And so there's how the string would work, 16.03.01.00, that's elbow range of motion impairment, and we're using 8 for the standard WPI, the adjustment factor of 1.4, and then you rate it out that way. So the pain is added to the WPI, and that's adjusted through the means of the normal rating string. So that's pain and how the 2005 PDRS looks at that. Well, what about headaches? Well, a few years back, the DEU also decided that, you know what, doctors are offering pain for headaches. What do we do about that? And they decided that, you know, yes, indeed, up to 3% for headaches without objective findings can be added. For it to be appropriately assigned as a headache, there should have been direct trauma to the head. And the DEU came up with an impairment number for that, and there it is, 13.01.00.99. The last 2 digits of 99 means it's not in the AMA guides. It's in typically assigned to Alvarez Guzman type alternative ratings. But that's the impairment number for headaches without objective findings. Well, it turns out the table 13.2, page 309 of the AMA guides within chapter 13, is used to evaluate impairment of consciousness and awareness, and that also uses impairment number 13.01.00. And one of the instructions within chapter 13 is that only the most severe of the cerebral impairments should be used. And cerebral impairments are all those discussed in tables 13.2 to 13.8 of chapter 13. So the question that is not universally, does not have a universal standard answer is, does that mean that 3% for headaches would be considered one of those cerebral impairments if there were others also assigned? So that's not answered, but it's just something to think about. Occasionally comes up if there is indeed a neurological injury. That's headaches. Our next topic, we're going to talk about combining or adding, and the CVC, Combined Values Chart. Anytime we put 2 numbers together in workers' comp, permanent disability rating, we are either adding them or combining them. And one of the challenges for us is to know when to do which. When do we add it? When do we combine it? And those 2 words have very different definitions with respect to rating permanent disability. So add and combine are not the same for permanent disability. So when do we combine and when do we add? When we're doing disability ratings, we combine most of the time. In fact, almost always, unless there's specific instructions to add impairment values. So the purpose of the combining and the combined values chart is to prevent a combined value from exceeding 100. Our maximum percents for permanent disability for WPI should be 100. And so what combining values does is it keeps us from getting above 100. When do we add? Well, the most notable exception for adding instead of combining is when we do the evaluation of range of motion for the same part of the body. For instance, if we have right ankle and we're doing range of motion evaluations there may be impairment values for 2 or 3 or 4 different motions. Those are added together. For the shoulder, we have 6 different motions that are evaluated. If there's impairment in more than one, those are added together. For the lumbar spine, for instance, there's 4 motions that are considered when we deal with range of motion for the spine. Those would be added together. So we add range of motion impairments for the same part of the body, but there's a very notable exception, and that's when you're dealing with the fingers of one hand. Rating the fingers of one hand is pretty complex. I'm going to talk about it here in a couple more slides, and kind of has its own set of rules that we'll reference again in a couple of more slides. But in general, other than with range of motion for fingers of one hand, we add impairments for doing range of motion. We combine most of the other times. So we kind of went through chapters 15, 16, and 17 to see if there's specific instructions within those chapters as to when to add or combine, and there are some. They're not always real easy to find. You got to look for them, and they're not under any section that's titled when to combine, when to add, but there are clues within the chapters that instruct when to add, when to combine. So in chapter 15, we add when we're doing range of motion method, specifically if we're looking at table 15.7 on page 404, we may have 2 or 3 different spinal disorders that we're dealing with for the same injury, and if we do, those would be added. Also, with the range of motion method for the spine, there are more than one motions that get evaluated for each region, for the cervical, thoracic, and lumbar spine regions, and we add those. So the instructions on table 15.7 tell us to add. Page 408 of the guides tells us to add range of motion impairments. When do we combine? With the range of motion method again, we combine spinal disorder with range of motion totals. Spinal disorder totals that we've added with range of motion totals that we've added. So with the range of motion method, there are 3 different elements potentially to consider. Those 2 elements, spinal disorder and range of motion, would be combined, and they get rated as one rating string. For upper extremity or lower extremity impairment for more than one nerve root, again, if we're doing range of motion method, that's potentially the 3rd element is nerve root deficit. If there's more than one nerve root, we would combine those as well. For chapter 16, some of the clues in there for when we combine and when we add, as we talked about earlier, range of motion for the same part of the body. For example, 4 motions. There's 4 motions for the wrist. There's 4 for the elbow. There's 6 for the shoulder. Those, if there's impairment in more than one motion, those are added. Again, added just for each individual joint. The exception is the evaluation of hands, multiple digits. It's really fairly complex and doesn't follow any real standard format. But the instructions within chapter 16 for combining and adding are summarized pretty well on page 511 of the AMA guides. But ultimately it says for the thumb, you add all range of motion impairment, the digit impairment level. For digits 2, 3, 4, and 5, so the other 4 fingers, you add them for the same joint and you combine them for separate joints. So it's no real standard format even between the thumb and the other fingers. So if you're rating a hand multiple digits, check the instructions in the guides. The next slide for upper extremities, we combine impairments from separate methods of evaluation for the same body part, including digits. And the instructions on page 511 also go through that pretty well. The upper extremity evaluation record on pages 436 and 437 also includes instructions on when you add, when you combine for doing multiple digits of the same hand. So when I mentioned separate methods for the same body part, for example, if you have a index finger injury, there's loss of motion and there's also digital sensory loss. The range of motion impairment and the digital sensory loss impairment would be combined for that digit. From the upper extremity evaluation impairment record, pages 436 and 437, one of the instructions in there I just wanted to point out, it says to combine regional impairment of the upper extremity. For California work comp, we don't use regional impairment, so we don't do that. And what that instruction in the guides is saying is, so it is telling a doctor if they come up with the total shoulder impairment, a total elbow impairment, a total wrist impairment, to combine those. We don't need that for California, but again, we have doctors that will do that because they're doing their best to follow the instructions in the AMA guide. So that's another inadvertent, not really an error, but an inconsistency that doesn't necessarily help us rate that the doctor has given us. We need to rate each body part separately, adjusted separately, as allowed in the guide. So for instance, the hand is rated separately, the wrist, I'm sorry, adjusted separate, not as indicated in the guide, as indicated in the rating schedule. The hand is separate, the wrist is separate, the elbow is separate, the shoulder is separate. So that's another thing to remember, that the doctors may be following the guide's instructions, but in this particular case, they don't help us. Continuing with the upper extremities, peripheral nerves, we combine sensory and motor deficits. Each injured nerve is adjusted separately. There's several different nerves that are addressed in the permanent disability rating schedule that are specifically addressed. There's another one that's just other, and those are for those that aren't specifically addressed. But if there's both sensory and motor deficit impairment for the same nerve, those values are combined. Chapter 17, the lower extremities. When do we add? When do we combine? Our pretty standard rule is we add range of motion for the same part of the body. And page 533 instructs us in that regard. And we combine these impairment values. Atrophy, the guides don't come right out and say it, but the example 17.4 shows us that if there's atrophy in both a calf and a thigh attributed to the knee, you would combine those impairment values. Strength, if there's loss of strength in flexion and extension of the knee, for instance, you would combine those impairments. It doesn't say that clearly in the guides, but example 17.5 shows that's how that is done. Arthritis, if you have arthritis for two portions of the knee, for instance, you would combine those two arthritis impairments. And for the knee, it's possible to have arthritis in both the patellofemoral joint and one of the lateral compartments. And if there is arthritis impairment assessed for two compartments, then those are combined. I mentioned the lateral and medial compartment for arthritis. If there's arthritis in both of those, only the greater is taken. So the knee, you have potentially you have arthritis at 3 different locations. And if we would only use at most 2. and those would be combined. Peripheral nerve injuries for the lower extremity, on page 550, it tells us that we would combine those as well. So there's sensory and motor deficits potentially. Those would be combined. So those are the clues we get from within the AMA guides as to when to combine and when to add. They're not always really clearly identified, but there are some clues within those chapters that tell us what to do. So how do we combine or add and use the combined values chart? Section 1 of the Permanent Disability Rating Schedule tells us, gives us some clues, still not completely clearly worded, but it tells us what to do. If there's multiple impairments, such as those involving a single part of an extremity, such as 2 impairments involving a shoulder instability and limited range of motion, for instance, we combine those. We combine them at the extremity impairment level. We don't combine them at the WPI level. We combine them at the upper extremity impairment level. The same goes for the lower extremity. If we have arthritis and a meniscectomy impairment for the same knee, we would combine those at the extremity impairment level. Then it's converted a whole person impairment, and we adjust with the rating string. We only adjust whole person impairments. Impairments with disability numbers in 16.01 and 17.01 are converted and adjusted before combined with any other impairment of the same extremity. So 16.01 is arm, 17.01 is leg, and then there are different impairment numbers and different ratings possible for those particular body parts. And the third instruction for combining within the Permanent Disability Rating Schedule, page 1-11, impairments of an individual extremity are adjusted and combined at the whole person level with other impairments of the same extremity before being combined with impairments of other body parts. And it tells us an example. You got a left knee and a left ankle would be combined before further combination with an impairment of the opposing leg or the back, for instance. So what this is saying is, if we have a left knee injury and a left ankle injury, we get the WPI, we rate each one separately, then we combine those, they're both the same extremity, and then we would combine with the back or the other leg, any disability from those. So how do we combine? The combined values chart is a nice way to do it. It's section 8 of the Permanent Disability Rating Schedule. There's 3 pages for the combined values chart, and it shows us how to combine. It gives us the actual combined value of any 2 numbers that we would use. It's based on the formula A plus B times 1 minus A, where all those are considered decimal equivalents, and I'll show you what that looks like in a moment. Combine in order largest to smallest, with the exception being you do an extremity first. And then after you do the extremities, whatever the same extremities, for instance, the left leg, the right arm, then we combine largest to smallest. For the same part of an extremity, we combine the extremity impairment value and then convert to WPI. So I'm just repeating that instruction we had. If it's the same part of extremity, we combine it at the extremity impairment value first. So this is what the combined values chart looks like in the 2005 PDRS. This is just page 1. There's 3 pages. And the way we combine is we take the greater number that we're combining find it on the left-hand column, and we take the smaller number on the bottom, across the bottom. And let me see if I can do this. Is it the bottom one here? So if, for instance, we want to combine 30% permanent disability with 20%, we're looking at 30%. We come across to where 20% is, and we see that combines to 44%. Again, there are 3 pages that go up through combining 99 with 99. So when we're doing the combined values chart, use the chart that's in the Permanent Disability Rating Schedule, Section 8. There is a combined values chart in the AMA guide, but there are 5 errors in it, and they're listed on this next slide, I believe it is. But if you're rating, you're going to have the schedule out anyway, so use that one. Those are all correct. This DEU corrected them when they published the schedule, and so they're correct. But here's the formula again, A plus B times 1 minus A. And this is what it looks like if you do the work. So again, assuming that A and B are decimal equivalents of the permanent disability. So 1 is 100%. So if we do this, we got a 30% PD for a spine, 10% PD for a right knee. That's what it would look like. It comes out to 37%. So you can do the math if you don't want to use the chart, but the chart covers every single number. No reason not to. If you're grading, you've got the schedule out anyway. Talk about it. Trying to ensure that it does not exceed 100% with the combined values chart. 99 combined with 49 is 99. 99 combined with 50 is 100, and then 99 combined with every number above it, including 99, is 100. It does not go over 100, and that's the intent. These are the corrections. These from the 5 errors that were in the guides. Again, they're corrected in the schedule, so that shouldn't be an issue for you. So I want to go through I'm going to have to kind of go quickly through an example of doing a combine and add. So if I'm looking at a March 5th, 2014 date of injury, a 41-year-old bus driver 41 in the date of injury, and the reason I'm saying 2014, I want to make sure we're going to use that 1.4 adjustment factor. Need to know that, whether we're using the 1.4 or the FEC values, the different FEC values potential from 1 to 8. So lumbar spine, we have 6% WPI. Here's what the doctor has given us. Right shoulder, range of motion, the doctor has given us these upper extremity values for the 6 different motions. We add those up. The doctor also has done an arthroplasty, a distal clavicle resection, and offers 10% upper extremity for that. So we have range of motion method for evaluating the right shoulder, 10% UE. We have arthroplasty, distal clavicle resection, for the same right shoulder, 10% UE. That's all we have for the right shoulder. We combine those upper extremity impairment values. 10 combined with 10 is 19, and then we convert to whole person. Right wrist, range of motion, we have these 4 motions, the 10% upper extremity, we add those all up first, and then we convert to whole person. Right knee, we have 2 different methods of evaluating the right knee. Arthritis, 1 millimeter of cartilage space left, 20 for cartilage interval, we have 25% lower extremity impairment for that, and then a meniscectomy, partial medial and lateral, 10% lower extremity for that. We combine those, they're both for the right knee, we combine them at the lower extremity impairment value, gives us 33% lower extremity. We convert that to 13% WPI. So we're not converting these at the extremity at each individual one, and sometimes doctors do that, and it sometimes creates a higher level of WPI. Another inadvertent issue from the doctor, because most of them are not familiar with some of the intricacies of the rating schedule, which tells us how to address that. And so there, with those same 4 body parts, we rate each of them out, and we come up with this. 8% PD for the lumbar spine, right shoulder, 15% PD, 8% for the right wrist, 18% for the right knee. And those are permanent disability, all for the same date of injury, and we combine them. We start with the upper extremity. We combine the right upper extremity. 15 combined with 8 were our permanent disability totals. That's 22. We combine that with the next largest, which is the 18, combined with the next was 18, so which is 8. Total of 41% total permanent disability. That's the end of that section. Combiner add is hearing loss. The next section we're going to cover. Chapter 11. Why did I pick Chapter 11, hearing loss? Well, I did have a couple of people ask me to review some of the things in that. And it's also a fairly easy chapter to review and gives some idea of what the AMA Guides looks like. So here we go. Section 11.1, page 246 is within Chapter 11 of the AMA Guides, talking about specifically hearing loss. Chapter 11 covers more than hearing loss, but this is the part we're going to cover. Page 246, it tells us assistive devices must not be used during the determination of a hearing impairment rating. And that's for those of us that did ratings prior to the 2005 rating schedule. That's important to know that, because prior to the 2005 rating schedule, we did want to know hearing aid assisted hearing values. We don't need that for rating with the AMA Guides. The criteria for rating impairment due to hearing loss, pages 246 to 251 discuss it, and I'm going to try to nutshell it a little bit. Page 247, it references again audiometric measures. So we need to get the audiometric measures from the doctor, and this is without assistive devices, so without hearing aids. Things we need to know about are decibels. We need to know this definition. Decibel is just the loudness. Scale of 0 to 100 is used. Below 0 and above 100, if there were someone that were measured as such, would not be taken beyond 0 and 100. Frequency is the pitch in hertz, Hz, and there's only 4 rateable frequencies. Although there are a number of different frequencies that get tested, we only look at 4 in terms of rating permanent disability, and that's the way it's been forever. So those frequencies are 500, 1,000, 2,000, 3,000, and those 4 are taken because most speech falls within these frequencies. So those are the ones that are considered most important in terms of work in the old days and activities of daily living currently. And so the way the hearing loss is evaluated, the doctor gives us a chart with decibels. When does the person being evaluated first hear each of these frequencies, at what decibel level? And that's what's being recorded. The decibel level at which each of these frequencies is first heard. How loud does it have to be? So from those 4 frequencies, we add them, and that's called the DSHL, decibel sum hearing loss. Within Chapter 11 of the guides, there's a couple of typographical errors where they put decimals sum hearing loss rather than decibel. So just a typographical error, it's decibel sum hearing loss. Table 11.2 of the guides gives us binaural hearing impairment, which matches the DSHL from both ears, and gives us, it doesn't give us, we also have table 11.1 gives us monaural hearing loss. Page 246 of the guides talks about tinnitus or tinnitus. I'm not sure which way that's supposed to be pronounced. But if there's tinnitus in the presence of hearing impairment, that may impair speech discrimination, and if so, the doctor can add up to 5% if it impacts ADLs. Example 11.2 clarifies that 5% is binaural hearing impairment. That's not WPI. Table 11.3 converts BHI to WPI. And so here's how we're going to go through an example. This is example 11.3 in the AMA guide. So we're just going to go through with that. So you might get from the doctor, you might get an audiogram with this kind of data. You got a right ear, left ear. We've got, actually the doctor gave us 9 different frequencies in the ratings. The only ones we care about are 500, 1,000, 2,000, and 3,000 for each ear. Although these others are probably useful for the doctor in terms of treatment and addressing hearing aids, they're not necessary in terms of rating permanent disability. So here's how that one worked out. It came with total 8% WPI for that individual based on that audiogram. So here's how it was done. The comments section of that example tells you how it's done. You take those four numbers, those 4 frequencies, and you add these. So you add these 4, 20, 15, 60, 80. For the left ear, you add these 4, 25, 15, 60, and 60. So that's the decimal sum hearing loss is just those 4 values added together. And I did it again. Here we go. I got it. Thank you. I was stuck on that slide again. So those 4 are added. So the DSHL for the right ear, just adding those 4 is 175. For the left ear, it's 160. So you combine these using table 11.2. And if we combine them, 175 for the worst ear, that goes along the left-hand column of the table, and I'll show that in just a moment. 160 goes across the bottom. We combine those, and we come up with a binaural hearing impairment of 23.4. That is not WPI. That's binaural hearing impairment. Table 11.3 converts that 23.4 to WPI. So the 23.4 goes to, converts to 8% whole person impairment. I've thrown in a rhetorical question. What if we add 3% BHI for tinnitus? Well, we add that to the 23.4. And we come up with 26.4 is binaural hearing impairment. We go to table 11.3 to get the WPI, and that gets rated. So, boy, that's hard for me to read. But that's table 11.2, page 1. That's table 11.2, page 2. Okay? And so what that has is, I'm going to see if I can do this again. We have the decimal sum, the DSHL here and a DSHL here, and you combine them and you get your binaural hearing impairment from that. Less than 100 for DSHL is not rateable. So if your value adding those 4 is 100 or less, it's not rateable. And it does not change what happens on that chart. Here's table 11.3. It converts binaural hearing impairment to WPI. So in that example where we added 3% for tinnitus, to the 23 point, I don't remember what it was, 23.8, it becomes 26.8, and so it increased it 1 WPI, 1% WPI. So that's what I have for hearing loss. One of the questions that comes up with hearing loss, has come up with hearing loss, is apportionment. Chapter 11 does not have a method for evaluating impairment for 1 ear. It's all based on binaural hearing calculations. So if you have unequal apportionment, if there's both ears are injured, hearing is damaged for both ears from an industrial injury, but unequally, perhaps there's a prior history of right ear loss, hearing loss, there really isn't a mechanism in the AMA guides for evaluating that. Or if only the hearing is only damaged for 1 ear, there really isn't a mechanism for evaluating that apportionment that way. There's no monaural hearing loss converted to WPI table in Chapter 11. So it's kind of, it's not clear. Some thought needs to go into applying apportionment if it's not equal for 2 ears, for both ears. The next topic is rating psych injuries. And Chapter 14 of the AMA guides covers, here we are, covers emotional disorders, psych injuries. And there's several pages within that chapter, but ultimately the authors of the guides decided not to put WPIs in there. Percentages are not provided to estimate mental impairment in this edition of the guides because there's no precise measures of impairment in mental disorders. So the AMA guide says, you know, here's how you evaluate it, but we're not going to give WPI. We can't do it. So we need to do something in California because we do rate psychiatric injuries. So what the DIR did when they created the schedule is they looked for different things, methods of evaluation. So they went to something the American Psychiatric Association was using. They were using the GAF scale, Global Assessment of Function Scale. Interesting to me is that it's the AMA, or the APA, American Psychiatric Association, stopped using it in their 2013 edition of Diagnostic and Statistical Manual. The GAF is no longer used. Just found that interesting. But anyway, the GAF is something that most doctors have been using in order to help evaluate where a person was in terms of their current status and any improvement or getting worse, and what to do in terms of treatment. So what we did for California in the 2005 PDRS, pages 1-12 through 116, it goes through the GAF. It talks about how to evaluate psych, and they assigned WPIs to GAFs. So GAF can be anywhere from 1 to 99 or 1 to 100, and page 1-16 of the 2005 PDRS converts a GAF to WPI. The higher the GAF is, the better the person is functioning, or the less severe the symptoms are, or possibly lack of symptoms. The lower the GAF, the higher the WPI. So again, the higher the GAF, the lower the WPI is. I just want to point out that in California, the 2 most frequently used GAF ranges, and the GAFs are given in ranges of 10. The 2 most frequently used seem to be a range of 51 to 60, moderate symptoms or moderate difficulties in function from a psychiatric perspective, or 61 to 70, mild symptoms or mild difficulty. For reference, the next higher GAF, 71 to 80, and I found that interesting. That doesn't mean, even though there's no rateable impairment, it doesn't mean that somebody might not have some symptoms occasionally. I just wanted to show an example to show how the different GAF assessments could impact a rating. So for instance, for these ratings, I used a 55-year-old property manager, and the first 3 up there, GAF 51, 55, and 60, are all within the range of 51 to 60, which is moderate symptoms. The range goes from 29% WPI to 15% WPI, and as you might see, a pretty significant change in permanent disability from 56% to 33%. These are, those three are all reflective of someone with moderate symptoms or moderate difficulty with function. That's a pretty big range. The next three, 61, 65, and 70 GAFs, can range from 32% permanent disability to 0. Another significant range of permanent disability, although all three of those indicate someone with moderate or mild symptoms or mild difficulty with function. American Psychiatric Association on this next slide, here's kind of sort of what they expect you to look at in terms of evaluating psychiatric impairment in the GAF. And the 4 areas of function: ADL, social functioning, concentration, deterioration, compensation. So there are some guidelines as to what the doctor should be reviewing. And here's some of the data that you might expect from a doctor in a psych report. Might be current complaints, activities of daily living, interpersonal activities and relationships, mental status exam, psychological testing. Psychological testing are all self-reported inventories from the injured worker. So I just want to, my ultimate point is that it's subjective. It's very subjective. It doesn't mean they're not accurate, but they are subjective. And a GAF of 52 given by a doctor might also be considered that 55 GAF is appropriate, or 57. So they're not exact assessments, is what I want to point out. They're not exact assessments, but ultimately doctors have to explain why they're giving what they're giving, not just with psych, but with any impairment. I quoted a portion of the 6th District Court of Appeals response in the Guzman decision of August 19th, 2010, and they're talking about substantial medical evidence. And it goes through what it takes to be substantial medical evidence, and ultimately a doctor has to provide evidence and reasoning for whatever they're telling you in a report. Substantial medical evidence requires evidence and reasoning to explain the opinions that the doctor has provided. So doctors do have some leeway, some latitude with respect to assessing impairment, permanent disability, particularly with Alvarez Guzman and their ability to provide alternative ratings, but they do need to provide evidence and reasoning. So in summary, this is what we covered. We covered Labor Code 4660.1. We discussed rating pain. We discussed headaches, how to combine or add, how to rate hearing loss, how to rate psych, and impairment recommendations must be supported by evidence and reasoning. And I think I have a couple of minutes and I'm going to take questions that have been sent to us here. So let me see what I've got. We have, the DEU found no rateable hearing loss, but the panel QME gave future medical for hearing aids. If the hearing aids are warranted, shouldn't there be rateable impairment? You think theoretically yes, but it could be that the hearing aids are for those frequencies that are not part of the rating equation. So the frequencies above 4,000 frequency and above. It's possible that the doctor feels that hearing aids are going to help the individual in those frequencies and make it appropriate. That's it. And that appears to be the only question that we have, so I'm going to let, are you given a final conclusion? I'm going to turn this back over to Tammy. Thank you all very much.